Good evening, everyone. So it is 6 o'clock, so we are going to go ahead and get started. My name is Sarah Coons. I work for the Epilepsy Association of Western Central PA in our office near Harrisburg. And we are so happy that you took some time out of your evening to join us this evening for the webinar. Some of you have been at all three previous webinars. Tonight is our last one. So we are very happy to welcome Dr. Lorna Myers to present for us at our very last webinar out of this series. I'm going to give you a brief introduction and then I'm going to turn it over to her and let her talk. While in training at a large epilepsy center, Dr. Lorna Myers encountered her first patient with psychogenic non-epileptic seizures, or PNES, and was immediately intrigued. Over the years, she has seen hundreds of patients who carry this diagnosis. She is the director of the Psychogenic Non-Epileptic Seizures program for the Northeast Regional Epilepsy Group in New York and New Jersey. She specializes in the research and treatment of psychogenic non-epileptic seizures and depression in epilepsy. She is certified in prolonged exposure and uses this to treat patients who are dually diagnosed with PNES and PTSD. In 2023, she co-authored the Psychogenic Non-Epileptic Seizures Pocketbook for clinicians and has published numerous articles in peer-reviewed journals. In 2014, Dr. Myers published a book for patients and loved ones called Psychogenic Non-Epileptic Seizures, A Guide. Dr. Myers donates the royalties of that book to Epilepsy Alliance America each year. And the EAWCP is an EAA member organization. Epilepsy Alliance America manages a scholarship program with that money for students with a diagnosis of psychogenic non-epileptic seizures who are pursuing higher level education at a university or college or a trade, technical, or professional school. Since we are a member of the Epilepsy Alliance America and Dr. Myers contributes to the scholarship that they have, we are going to put in the chat a link to the Epilepsy Alliance America's mailing list. So if you would be interested in receiving emails from the Epilepsy Alliance America, you can click on that link and fill out the few short questions to be added to their mailing list. So I am going to now turn it over to Dr. Myers.
Okay, well, thank you very much. And thank you for joining me tonight to talk about non-epileptic seizures, a real passion of mine. So just so you know a little bit about how we're going to approach this tonight, initially I'm going to start talking about what PNES is, because not everyone may know what we're talking about when we refer to PNES, which is psychogenic non-epileptic seizures. And then we'll talk about a few issues that come up with non-epileptic seizures in terms of what's most important. There's a lot of debate, you may not know this, but a lot of debate academically about what we should call these seizures, and then the importance of giving the diagnosis correctly and then providing treatment. And so really the second half of the talk is about treatment, because I think that's what most people are interested in, and that's really the important part of this talk tonight. Okay, so next slide, and I do have to give all of these, you can go to that, yeah, there we go. So I don't have any actual potential conflicts of interest in relation to this presentation, but I do receive royalties from intellectual property for the Psychogenic Non-Epileptic Seizures Pocketbook and non-epileptic seizures education.com. And I do not receive royalties from the guide, the non-epileptic seizure guide, because it is all donated to Epilepsy Alliance America for that scholarship. Okay, next slide, please. So we're going to have some take-home messages. First, I'd love for you to know when you leave here, what is PNES? Two, are we as clinicians, as scientists, focusing on the right issues? Third, the importance of the diagnosis and the referral, and that they're made in a way that they actually work, and that can make a huge difference in prognosis. And then I want you to know that there are a growing number of treatments available for you to know that there are actually choices that you can make. Next one. Okay, So PNES versus epilepsy, the one thing with PNES and epilepsy is that they often look very much alike. So a non-epileptic seizure will resemble an epileptic seizure. They can often have involuntary movements of body parts, alteration of consciousness, paralysis, vocalizations, but they're not associated with abnormal electrical activity in the brain. So if the patient is hooked up to a video EEG monitoring machine, you will not see the epileptiform activity that you would see with an epileptic seizure. And epilepsy is very much similar in presentation, but there is the associated abnormal electrical activity. And that's really how most neurologists would differentiate the two. Okay, so next one. There's a big issue with PNES, and it is the issue of misdiagnosis, because they do often look so much like an epileptic seizure. If the patient is, let's say, tested with a 1-hour EEG, is not tested in a prolonged testing situation, the diagnosis can be made incorrectly. So often patients will report that they've been treated with anti-seizure medication for many years, and the average time between first seizure and a definitive diagnosis is around 7.2 years. I do believe this number is a bit dated, and I think that this is getting better now, because just from anecdotally talking to patients who come to my office, I seem to see that patients are getting a diagnosis quicker than that. But there are still patients who have had to wait years for the correct diagnosis. And the issue with PNES is also that it looks so much like epilepsy that if a patient has been diagnosed with PNES and is sent to a psychiatrist or psychologist for treatment, and they have a seizure in the office, the therapist will often think that it is epilepsy and send them back to neurology. So there's often a sort of questioning of the diagnosis, and it ends up producing this sort of ping pong effect where a patient is diagnosed with PNES, sent to psych then sends them back to neurology, and so forth. And they keep going back and forth, and it's just terrible because time is lost, years go by. So the issue of misdiagnosis is very important for PNES. And next slide. So how is PNES diagnosed? If anyone in this talk has had a diagnosis of PNES, you'll probably know that the gold standard for the diagnosis is something called video EEG. That's one of the machines that you can see there. And video EEG is an EEG simultaneously with a video that is recording the movements that the patient makes. And then the epileptologist looks at those two inputs and sees whether the events appear to be epileptic or not. Now, there are a few issues with this. One, usually you have to have enough events that have been captured, enough typical events. So if someone has one episode, and is there for several days and does not have anything else, there's always a question of whether that's the only issue that's going on. Is that the only episode that they have, or is it possible that something got missed? So usually the epileptologist will want to have at least 3 typical seizures captured. Everybody knows that's really difficult to do, unless you're having multiple seizures a day. Sometimes you can go the whole test without having an episode. And sometimes people complain that when they're in the hospital, they are somewhat less stressed, and it's sort of an artificial setting, and so they may not have anything. And it's very frustrating because that sort of prolongs the time that it takes, to actually get a diagnosis. There's also something called an at-home, an ambulatory video EEG that also lasts around 3 days. Typically, at least in our practice, I see that patients are brought in on Friday. You have the machine during the weekend, and then on Monday, it's brought back. That way, if you're working or anything like that, it interrupts as little as possible. But that's the gold standard. And a lot of times patients have not been tested in this way. Sometimes you'll see that patients have been diagnosed with PNES without this testing. And really, in this day and age, that is the most the testing that gives us the greatest confidence in what we're telling the patient. For me as well, if I am treating someone with psychotherapy and I'm not certain if this is PNES or if this is epilepsy, it makes me less confident in my approach. So for the most part, with patients that I see in my program, everyone has to have a confirmed diagnosis of PNES with this testing. And I think that's becoming sort of a general practice in the US as well. Next slide. So just a few issues, that sort of things that sort of get stuck in my head, that I wanted to bring up today. Because the issue of stigma with PNES is a major one. I don't know how many times I hear patients say that they have been treated very poorly, either by EMTs or NERs, by doctors, by nursing, and so forth. And let's not even get started with the general public. So the issue of stigma in epilepsy and in PNES is a big one. With PNES in particular, the problem is that it's not a common thing, but it is something that you see more than you should. There is, for whatever reason, mistreatment of patients, sometimes by health staff. And so there's been a movement in the academic world where the thought is that, well, perhaps we can combat this stigma by changing the name. So, for example, instead of calling these episodes pseudo seizures, right, which is something that this disorder used to be called back last century, and which was very problematic because pseudo means fake, and so then that created even more of a stigmatizing attitude from some clinicians. But so the sense is that pseudo seizures, that has been abandoned for the most part. Some doctors still do use the term, but I think it's growing less and less. The newer term is PNES, which is Psychogenic Non-Epileptic Seizures. And more recently, there's been a push to change the name to functional seizures or functional dissociative seizures. And really, I think it's coming from the right place, which is thinking that if we change the name to make it less psych, it will be less stigmatizing. The problem is that patients and clinicians are getting more and more confused because there are more and more names. There's always something new that's sort of coming down the pipeline. And the issue is that by relying so much on the functional piece and not presenting the psychological piece, which is there, it gets harder and harder for patients to follow through with treatment referrals to psych. And when they do follow through, the first few sessions are spent having to have discussions about this because it's obviously unclear to the patient that they've been told that they have something that is not psych, but they're being sent to psych. There are other things in terms of nomenclature. There are some doctors who are very, very resistant to using seizure when they're talking about a psychogenic non-epileptic seizure. Some patients will be almost scolded because they're using the word seizure instead of event or episode or attack. So we can really we could spend the whole night talking about this. And honestly, I don't think that this is the most important thing that we need to be talking about. Yes, stigma is important, but if we go to the next slide, I think that we need a different approach that goes beyond changing the name yet again. I think that, and this is my opinion, but I've been doing this for over 20 years. My sense is that what we need is more comprehensive education of the for health professionals. In terms of mental health, mental illness, really encouraging health professionals to check what are their biases and their preconceptions about mental illness, and especially with a disorder like PNES that bridges the mental and the physical. I think that one of the big issues, one of the big problems that we run into is that the problematic health professionals are typically, when they see a patient with PNES, they are seeing the patient from a volitional interpretation of PNES. So they're seeing them like they are purposefully doing this. They are in control of their episodes. And you will sometimes hear clinicians say the patient is seeking attention. The patient is doing this to avoid something, or the patient is not getting better because they're just not working hard enough at it. So they're putting all the responsibility and seeing the patient as purposefully producing the episodes. This could not be further from the truth. This is just so inaccurate, because actually the mechanisms that create non-epileptic seizures are extremely complex, and they are almost always outside of awareness. Sometimes patients have altered awareness. Many patients are unconscious during the episode, so they are outside of awareness. And they're due to a whole bunch of things, and I'm just going to throw these words out, but, we know that they are due in part due to interoceptive deficits, right? Which just means having difficulty sort of getting the signals, detecting and understanding those body signals that we're getting. Alexithymia, having trouble sort of identifying what it is that I'm feeling. Often in patients with PNS, there's a disconnect from the body. There's sort of a detachment, almost like I'm a head and my body's over here. Patients with PNES tend to somatize, so they tend to turn emotion or tension into physical symptoms. So there's a whole, it's just like a massive, complex mechanism that is really hard to understand, even for, mental health clinicians. And so that, to see a patient as purposefully doing this is a very simplistic and inaccurate way of seeing what's actually happening. Okay, so that's how I think we need to combat stigma, but that's a lot of work. It's a lot harder than just changing a name. And we're not going to fix it tonight, but I just want to put that out there, that's where I think we really need to be going. Okay, next slide. So I have a website. It's called non-epilepticseizures.com. It's an educational website, and every year we do a new survey. So a survey that we did a few years back was, what should this disorder be called? And we got a total of 262 votes. By the way, this is not a scientific vote. This is not a scientific survey. But I thought it was interesting that over 50% of the people who responded picked PNES. FS was next, and then the other two were smaller percentages. This was a few years ago. This may have changed now somewhat, but for the most part, I anecdotally do ask patients when they come in, not every single patient, but a lot of patients that come in, what do you think this should be called? Or what were you told it's called, and how do you feel about that? And next slide. For the most part, what I get is that patients are usually not that interested in what it's called or not called. There are some that are, but for the most part, patients are not all that interested in what we're calling this. Rather, what they are interested in is in getting their seizures managed and taken care of. They want to have no more seizures. So that's really where their focus is, and I think that's where our focus should be as well. And if we have time left over, then we can talk more about the nomenclature. So what we need to be able to help these patients is one, a respectful and clear presentation of the diagnosis when it's made. So often I hear patients have been told a very confusing, you don't have epilepsy, you have something else. Maybe, they throw the word functional there, or they throw non-epileptic seizures. Then they get told maybe these are not even seizures, and then they get sent out the door. And again, the biases that the clinician has will seep into that. So if they have an issue with anything psychological, in terms of mental health, then they will be uncomfortable presenting the diagnosis when there should be no discomfort. We'll talk now a little bit more about how the diagnosis can be presented, but there's nothing shameful about having perhaps issues with emotional dysregulation. A lot of us do. So that diagnosis needs to be presented clearly, and then a proper referral for treatment. Too often I hear patients say that they were sent out the door with nothing. No name, no phone number, nothing. That's not acceptable. You're being given a very difficult to understand diagnosis, and you're being sent home without a referral. And then last thing that is needed is the provision of treatment. Treatment that actually leads to seizure freedom. Treatment that is the target. The target is the seizures. If one treatment doesn't work, there are other treatments, but that's where we should be going. Give the right diagnosis, give it clearly, explain, answer questions, provide a referral, and then provide treatment. Next slide, please. So we had another survey on our website, non-epilepticseizures.com. And the question was, when the doctor gave you the diagnosis of PNES, did you receive the name of a psychotherapist, name and number of a psychotherapist? And you'll see that only 17% responded yes. And that's not okay. That's a real problem. So that's something that I think is urgently, we need to fix that. Next slide. So, very busy slide here, but basically, some people may take a picture of it. There are several sources where there are lists of professionals who work with PNES. And so even if a epilepsy monitoring unit is in a state where they don't have anyone who works with PNES, they can, at the minimum, provide these resources. One is non-epilepticseizures.com. It has a referral tab. On that referral tab, there are psychiatrists, psychologists, counselors in many different states and even in some different countries. And something that is really, really positive in the last few years is there is something now called PsyPact, which means Psychological Interjurisdictional Compact. It basically means that there was an agreement made between states that allowed licensed psychologists to practice across state lines. And now they're up to 39 states and districts and commonwealths. So if a psychologist is, let's say, in New Jersey and the patient is in Florida and there's no one around in Florida who can treat that person, they can still be treated virtually by this person who's in New Jersey, for example. So that's really opened up, the availability to clinicians who work with PNES. Then there's also fndhope.org. They have a Find Provider tab. And then there's the International Society for the Study of Trauma and Dissociation, which also has a Find the Professional tab. Okay, so these are at least 3 sources where a patient can begin, rather than just being told, find a therapist and calling therapists willy-nilly and asking, do you know how to could you treat my non-epileptic seizures, and having to educate the therapist and this and the other. These are three resources where you have a much bigger likelihood of running into someone who actually knows what you're talking about, and can actually treat. Next slide. So presenting the diagnosis, we talked about, how important it is to present the diagnosis in a way that is clear. And every neurologist will use, different words, because everyone is, is an individual and feels more comfortable with certain wordings. But for the most part, what we know about PNES is that it's a brain network disorder. So it doesn't show up on EEG, but there is definitely something that is happening in the network itself that is not functioning the way that it should be. And that results in physiological and psychological dysregulation. So physiological, what starts to happen is that there are issues with sensory motor processing. Patients will say that they're triggered by lights, sounds, crowding, being in certain situations that are overstimulating. So there is that part, as well as difficulty identifying the body signals. We talked about that before, having trouble sort of picking up those signals. I'm tired, I'm hungry, I'm stressed, I'm angry. And then the other part of the system that is affected is the emotional functioning. There tends to be under or overreactivity. So sometimes a patient will encounter something that you would expect would make them angry or upset or something, some reaction, and there's nothing. And that doesn't mean that nothing's happening. It's brewing under the surface. And then maybe a day later, a seizure will happen. Or overreactivity. So there's a tendency to really sort of be out of that nice window that we aim for, the window of being sort of regulated in a comfortable zone. There's a tendency to be either above or below, and to go up and down, right? So a bit of a roller coaster experience. And so that leads to dysregulation. And so that is what really leads to the seizures or the dissociative episodes. There's this going on. There's a lot of dysregulation. There are difficulties identifying body signals. There's a tendency to be overstimulated in a sensory manner. There's a tendency usually to avoid rather than directly problem solve. And so all of that leads to what you could consider as a short circuit and the seizure. Next slide. Other issues when the diagnosis is being presented is not just to give an explanation like I just gave, and with a lot of questions, right, thrown in, but also for the physician to make sure that the patient understands that it's a very serious disorder. This is not, this is not something that you're just going to will yourself to get better, which is the problem when physicians are looking at this as a volitional disorder. And if it's left untreated, it can become chronic and it can be disabling. And actually, by the way, some of the episodes, if they're very violent, they can be harmful. Patients do injure themselves with these episodes. There used to be a myth that PNES never resulted in injuries, which is not true. So it can be chronic and disabling if it's not treated. What is important is that the patient understands that when at all possible, it's important to avoid potentially harmful medical treatment. So if possible, if it's a typical episode, try to avoid the ER or hospital admission. And instead, all that energy needs to be put into finding the right treatment. Okay, next slide. Now, all of this, and now the positive. The positive is that 20 plus years ago, there was absolutely nothing in terms of treatment for PNES, believe it or not. It's not that long ago. And patients used to basically be sent, that's when you would really see the ping pong effect. Patients would be sent to a general psychiatrist or general um, uh, psychotherapist, and they would be sent back. Now we're in a very different place, and there are actually several different types of treatment, types of modalities of treatment that have been that are being studied, that have been reported on, including, and you see here a list: mindfulness-based therapy, CBT, um, prolonged exposure therapy for patients who have PTSD and PNES, psychodynamic therapy, which is sort of the more classic psychoanalytic therapy, group therapy, and psychoeducational groups. Next slide. And so the beauty of having many different modalities is that not everybody responds or likes every single modality. Therapy is a curious endeavor in that there is there needs to be a match or a fit between the intervention and the rationale for the intervention and the patient. There also needs to be chemistry usually between the psychologist or the psychotherapist and the patient. There's a lot of variables that are in play. It is not the same as just giving a medication, perhaps, and that in itself is going to work. So this is why I like that there's several different types of treatments, currently. Mindfulness-based treatment protocol for PNES was developed by Gaston Basselet in Boston. And as we know, mindfulness is really an effort to be present, an effort to also be much more aware of your values, of your goals, but to be present and accepting of the fluctuations that you experience during your day, while being very present and aware of what's happening with your body and in your head as well. That's a very rough definition of what mindfulness is. A very, very, very poor definition. But anyhow, that's sort of the gist of it. The important thing is that with this MBT protocol that is 12 sessions long, what Basselet reported is that at the end, they saw a significant reduction in seizure frequency and intensity. And this is important because it's one thing that a patient might have 10 episodes a day, but also sometimes it's not just the number, but it's the intensity. Some episodes can be very violent, very, very charged. And if the intensity goes down to where the patient is perhaps not moving or maybe having minimal shaking versus an intense sort of thrashing episode, that's a big difference too. So what they saw is significant reduction in seizure frequency and intensity, at least by 50%, and better quality of life by the last session. And at 6 months, they did a follow-up, and they found that seizure frequency remained decreased from the baseline. So just keep in mind that mindfulness-based treatments are available, and these treatments have been tailored to work with PNES. This is not just your run-of-the-mill mindfulness. This is a tailored protocol. Dr. Basselet actually, he has not published his manual, but he offers it for free. So anyone who wants to access it, a therapist who wants to access it, you contact him, and he gives you a Google Drive link, and you can access it. Okay, next slide. CBT is probably, cognitive behavioral therapy has gotten the most sort of PR in treating PNES. They're the two most known names in CBT for PNES for adults are Kurt LaFrance and Laura Goldstein. Kurt LaFrance in 2014 published his results from a multi-center randomized controlled trial. And what they found is that CBT informed psychotherapy that was designed, tailored to treat PNES, to treat the seizures, resulted in a significant seizure frequency reduction. And it also resulted in improvements in depression, anxiety, quality of life, and global function. Goldstein did another study that was published in 2020, and unfortunately found that compared to treatment as usual, initially the patients seemed to have done well, but at around 12 months, they were not finding a significant difference in seizure frequency. There could be a lot of reasons for this. It could be that they really sort of recruited patients of all types, and they were not very selective in the patient recruitment. Could be that they were not doing video EEG monitoring on all of them, so there may have been patients who had something other than PNES. And it could also be that if you go through treatment and you do well, a lot of times I would recommend to continue with some sort of supportive therapy, just to make sure that you stay on track with your self-care and with your stress management. So, we could talk again all night about why we think that these were the results that Goldstein got. But keep in mind that if you see here on the left, treating non-epileptic seizures, that's actually LaFrance's book. That's the therapist guide, and that treatment is being offered in a lot of places here in the U.S. Presently. Next slide, please. There's also psychodynamic interpersonal therapy. That's more the psychoanalytic approach. It's longer. This is more for patients who are perhaps more interested also in looking at their history, versus CBT, where you're more focused on the present. You're focused on, understanding your behaviors and your reactions to things and how you're thinking and how to change the thoughts in the here and now. With psychodynamic interpersonal therapy, you're looking more at your past and your history and how that connects with the present and how you are developing these seizures. This type of treatment is longer. This was around 20 sessions, but they also saw there was a reduced seizure frequency and severity by the last session and at follow-up. And there was also less of a tendency to seek healthcare treatments that weren't needed, for example, going to ERs and hospitals. Next slide. Group therapies. There are some people who enjoy being in a group. Some people would not want to be in a group for anything, right? But there are two group therapies that have been reported on. Both of them were helpful in that they found that at the end there was a reduction in seizure frequency. One was a more psychodynamic type of group. It was long, 32 sessions. And then there was one that was DBT approach, 20 plus sessions. But both of these group therapies, the positive that I'm focusing on is that they did find that there was a reduction in seizures at the end of these. They did not do a follow-up afterwards, so we know just the last session. Next slide, please. And then there is something called prolonged exposure therapy. Again, this is 12 sessions. This is something that I have been working on with my group now for a number of years. In 2017, we published an uncontrolled case series with 16 subjects that had received prolonged exposure. Prolonged exposure is a treatment that was designed for PTSD, and what we did is we modified parts of it so that it would also target the seizure symptom. So if someone has both diagnoses, usually this is where I would start. I would start with PE. It's a very intensive treatment, but what we saw is that the majority, 81% of patients reported no seizures by their final session. They had also improved in terms of depression and PTSD symptoms, and our follow-up revealed sustained gains in seizure frequency. Now there's, at this point, this is very special this month because for the last 5 years, we've been running a randomized control trial looking at prolonged exposure and comparing it to an individual psychoeducational treatment. And this month, we will actually finish our data collection and we'll have the last 2 patients, their 12-month follow-up. So it's very exciting from our perspective because it has taken an inordinately long time. We started March 2020, COVID. We had to shift gears, go from doing this in person to virtual, rewrite our IRB, this, that, and the other. So it really has been a lot of work, but it's been super exciting to see the patients and to see the effects of the different treatments. I've got to say that the numbers are not there yet because we're missing these last two subjects. But for the most part, what we're seeing is that in both branches, patients, a significant number of patients improved. So I don't know what I'm going to make of that, but it's just been really excellent to be able to provide this treatment. It was provided for free, and to see patients really doing great on both of the treatments, in fact. Next slide. Okay, and I really want to leave you with some additional resources. So we talked about all those resources for obtaining referrals, for obtaining a clinician who is familiar or has expertise with PNES. Other thing is that the book Psychogenic Non-Epileptic Seizures, a Guide, is a book that I wrote, several years ago. It's a little dated. I want to work on second edition. I keep saying that, and I really need to do that. But it is still a valid guide, a valid introduction for patients and for their loved ones, explaining what is often very confusing. Very confusing delivery of the diagnosis, very confusing being sent out without any sort of referral. So this is basically a guide that talks about everything that we understand in terms of risk factors, in terms of triggers, in terms of seizure logs, certain tools that can be used, and so forth. There's also this website, nonepilepticseizures.com. And you heard already about the scholarship that is managed by Epilepsy Alliance America, scholarship for patients who have PNES. Next slide. And then there's some resources for professionals who are seeking to continue their education. There's a new website that includes webinars for professionals who work with adults and pediatric PNES. Different short 20-minute courses that are really directed at all sorts of things that can come up, safety in the office, working with families, working with, for example, patients who have PTSD, and much more. There's also the Psychogenic Non-Epileptic Seizures pocketbook that was written. It's almost like we have the guide for patients, and then there's the pocketbook that was written for clinicians who perhaps are seeing their first PNES patient, really don't know what this is, but they're interested in learning, and they want to have something that they can sort of flip through if they have a question about how the diagnosis is made, or how to keep my patient safe out of the office. There's also the Treating Non-Epileptic Seizures Therapist Guide by LaFrance and Winch. And hopefully very soon, Gaston Basselet is going to publish his mindfulness-based treatment manual for FDS, for functional dissociative seizures. He's promised that he's going to work on that, but he's been incredibly busy. I really hope he does publish it, because that way many more people will have access to it than just contacting him and getting his Google Drive folder. And with that, I think that's it. So we're open for questions. Yeah, that's my email, just in case if anyone, sometimes this happens, once we hang up, you have a question, you're like, I forgot to ask this, or maybe you didn't want to ask, maybe this is a personal question, so you can send that. Give me 2 days, more or less, to respond. I always say, give me 2 days. If you haven't heard back from me in 2 days, then send me another email, okay? A nudge. Because sometimes it got lost, or sometimes, I don't know, I was distracted and missed that one email. So, okay.
Perfect. Thank you, Dr. Myers. That was an amazing presentation. And we do have some questions in the chat. So Allison asks, are the DSM-5 and the ICD-10 state different terminologies or different umbrella terms?
apologies. The DSM is going to call this conversion disorder or functional neurological disorder. Yeah, because now there's functional dissociative seizures, functional seizures, but it's functional neurological disorder or conversion disorder. And that's what I mainly use. So the ICD, I'm not 100% sure, so I don't want to say. Okay, I don't want to say something that's wrong. But functional neurological disorder and conversion disorder is what you'll typically see. And someone saying dissociative disorder. Yes. Thank you. Thanks.
And then we have another question from Allison. She says, you talk about seizures mainly as epileptic states, but can you talk about changes in behavior or awareness, such as episodes of regressive behavior to earlier age, please?
So you're talking more about a dissociative identity disorder, perhaps?
Allison, if you want to unmute yourself and kind of elaborate on that.
Yeah, hi. Sorry, I'm in England, in the UK, so I'm keeping my voice down because it's very late. So yeah, I just obviously in the when you're describing non-epileptic seizures, PNES, it kind of states that it can look like epilepsy or changes in behaviour or awareness, and I have had a familial situation where my daughter had chronic non-epileptic attack disorder in the UK, we call it, and amongst various other different terminologies, and she had a regressive behaviour to when she was a child, so went from chronic epileptic states to then different states of seizures and regressive behavior where her gait changed and her voice changed. Thankfully she's recovered now, but I have never ever I've been in touch with you on LinkedIn.
I'm so happy to see you.
Yeah. But I've never ever come across any papers or literature or any other person that talks about this change in behavior.
Thank you for bringing that up, Allison, because you're right that you're right. I don't think there is a single paper, but I have seen patients that behave in the way that you're describing.
Right.
Yes. So she's not alone. And it can be very disconcerting, obviously, for the family, right? But this is probably having to do with dissociative identity, regression. We're talking more psychodynamic in the approach to understand it. And the patient will actually regress and speak perhaps like a child or move like a child. Luckily, for the most part, it is temporary, and then the patient will emerge from that. But it can sometimes happen repeatedly. So I'm glad you brought that up, because that is something that at least they study, right? So that
it does.
You don't feel that she's the only one, the only odd duck who has this, because she's not. I think it's probably because the diagnostic part is usually dealt with by neurology, and so neurology is sort of focusing more on the behaviors that look like epilepsy, or they're diagnosing within a time limit, and I've usually seen this type of behavior emerge later on, after the diagnosis has been given, perhaps something it's been longer term, and then this starts to happen.
That was exactly the case, because it was the convulsive for about 5 or 6 months and completely immobile with convulsions, but then went completely mobile but couldn't see us.
Yes.
It was really quite an oddity to see, but we were one of those people that were kicked out the door without anything. which is hence why I've gone on now to do research on it in Wales. And the other thing that interests me is multiple cases within a family, because both of my daughters had it at the same time.
Yes.
So,
but it does happen. Yes. So again, you have the, I guess, the fortune, or but
I know.
unique that the regression that is seen. It's not in every case, but it is seen, and then it does happen that sometimes mother, daughter, or siblings, aunt and niece will have this disorder. Yeah, go ahead.
It was because it was both my daughters within a month, but both with different origins. One of my daughters has a late diagnosis of autism, which is another field which is really interesting, and the other daughter is born out of being born with a duplex renal system and having multiple surgeries, and so you say, I'm fortunate. I mean, in another kind of way, it's quite strange because I seem to have had all of the experiences in one.
Because Alison has actually been studying. She went on to study, right? Do you have a master's?
Yeah, I'm just finishing it now. I've finished my research now.
It's just wonderful also for Wales, because now she's going to be, a resource there for all these patients that, like you said, they're often shuffled out the door with no resources, no explanations. And so I think that, yes, you're right. The regressive behavior and then that it can sometimes occur in the same family. It's not super common, but it can. And then the fact that these seizures, they change. And so that's something to keep in mind. That's one of their characteristics, is that they are changing over time. So often they will start one way, let's say with a convulsive episode, and that goes on for a while, and then they change to perhaps being loss of tone or something else. And that's usually sort of a hallmark that, if they are changing over time in really sort of dramatic ways, and there's multiple types of episodes, it's just something to think about. This might be non-epileptic.
And sorry to take up your time, but I just wanted to point out as well that when we're talking about somatic symptoms, my youngest daughter, who was chronically ill, also had an experience of unexplained vertigo when she was very young, and I was warned that to watch out for something else, because somatic symptoms in non-epileptic attack disorders can just come in any form.
Correct. Yeah. And that's where they fall under the umbrella of functional neurological disorder, which can present with blindness, paralysis, sensations, stuttering, difficulty speaking, swallowing, et cetera, et cetera. There can be all of these different types of symptoms, and the seizures fall under that umbrella of functional neurological disorder. Yeah. Mm-hmm. Very good. Well, thank you, Alison.
Thank you.
Yes.
Thanks for those great questions, Alison. Tracy had a question. She said, what is the difference between PTSD and NEPS? Did you mean PNES, Tracy? If you want to.
Yes.
Okay, so what is the difference between PTSD and PNES?
So, very good question. Thank you, Tracy. PNES is what we talked about at the beginning. It is a disorder that presents with what looks like an epileptic seizure, usually, but it is not an epileptic seizure. So it's not, but it looks like. And it can present with all types of bodily symptoms. For example, convulsions, shaking, loss of tone, vocalizations, or muteness, and in addition, consciousness is usually altered, which means that things maybe sound far off or sound different, or things look different, or they can present with unconsciousness. And there used to be a myth that with PNES, patients were always conscious, but that's not always the case. So PNES is basically seizures that are non-epileptic. PTSD is post-traumatic stress disorder, which is a disorder that someone develops after they have experienced a traumatic event or multiple traumatic events. And it comes with certain symptoms. So there is, it's basically produced by the trauma itself and then how the patient dealt with that trauma through avoidance, through trying to not think about, trying not to remember, trying not to read into anything that is a reminder. And it ends up producing intrusive symptoms, nightmares, intrusive thoughts, that the patient is constantly trying to not think about. It also produces hyperreactivity. So there's startle, if someone behind, there's person jumps, is very alert, very aware of their surroundings, and can have trouble sleeping, for example, have trouble even, reaching a calm state to be able to sleep. And there is the constant avoidance of these thoughts and really sort of almost playing whack-a-mole all the time, whack-a-mole with, all of these things that keep sort of coming up. And it ends up causing a really serious condition where the patient is more and more withdrawn, typically, trying to avoid all of these, distressing reminders. And it also comes with depression often, and it can be quite disabling. So this is typically, when you talk about veterans, this is where PTSD sort of became better known, sort of more known to in general. War experience, or a sexual assault, that sort of thing can produce PTSD in the long run. Yeah.
So can that be non-epileptic seizures because from PSD?
Well, yes. I think that the way that I see PTSD and PNES is that PNES is really a much worse symptom within PTSD. It's if we talk about PTSD being maintained by avoidance, PNES is an amazing avoidance mechanism. It's an unconscious avoidance mechanism. But if you're in an argument with someone and you have a non-epileptic seizure, usually the argument is done, right? No one remembers what was being said because it's an emergency. And so without meaning to, that seizure helps to avoid whatever was dysregulating, right? So PTSD, you have avoidance, you avoid thinking, you avoid, sort of you avoid speaking to someone. That's conscious. PNES is unconscious. So that's what I mean that it's 2.0. It's a
I understand.
worse symptom because now it's out of your control. You don't even know what that your brain is doing this to protect you.
Right. Like the doctors say that my brain's doing it to protect something that's happened in the past.
Yes, exactly. And that's usually what I would say. I would say your brain is doing this to protect you, but the problem is that it's now sort of on autopilot, and it has gone from being a mechanism that's meant to help you to actually making a mess, because it gets triggered whenever. And so the treatment, would aim to reteach the brain that when you're facing something that's really, really disturbing, that's really distressing, you don't need to have a seizure. But we can't just tell the brain that, just say like, listen, we have to actually go through the treatment, through the experience, to retrain the brain that instead of having the seizure, let's just sit here with this very uncomfortable feeling. And it takes 12 weeks, right? I mean, it's not that long. if you think about it, because sometimes these seizures have been going on for years. But with PTSD, post-traumatic stress disorder, it takes 12 weeks to really sort of make a dent in the seizures. Yeah.
I got one other question. You said some of them can be more aggressive, than other ones. And should I mark all my seizures down? And like sometimes my husband will say, boy, that was an aggressive one. You really jerked a lot. Should I tell my doctors when they're more aggressive than others?
You could, because it actually, like I said, we're looking at when we're doing treatment, not only is the seizure frequency going down, but also is the intensity going down. The aggressiveness of the seizure, I mean, there could be a lot of things going on. Maybe that you had pent it up, you had built up more and more, and then it comes out in a much more sort of violent way, with a lot more thrashing and everything else. But definitely you can mention it, and you can even sort of keep track, when am I having sort of milder episodes and when am I having, some sort of more aggressive. Yeah.
So you'd be somebody I would really like to you gave me your website. You said I can contact you if I have a
If
question?
you have a question, a lot of people send me emails all the time. Yeah. That's why I say if it's 2 days past your email and I haven't responded, send another email, okay? Because I get a lot of emails from all over the world. Sometimes asking.
I've read almost every one of your books.
Well, thank you.
Thank you.
All right, it looks like we have one more question in the chat. It is from Laura. She asks, what are the relationship of PNES, ADHD, and high-functioning autism? Can the PNES affect a student's memory?
So this is a little, I thought of this when Allison mentioned, her daughter with autism. This is something that has also not been studied and that we really do need to look at, because more and more I'm seeing patients that I suspect have high functioning autism, which would sort of go in with perhaps the social perceptions or misperceptions. We know that PNES can be sort of triggered by emotional dysregulation. Sorry. And so someone who has perhaps high functioning autism is functioning in a social setting that is perhaps stressful in itself. And that we're talking about alexithymia, for example, not being able to really read your emotions correctly, or not being able to read what's going on outside, or not knowing really how to counter whatever happened outside, how to have a problem solving in a social situation. So all of that could be impacted in someone who has an autism, who's on the spectrum. And so that could very much be a risk factor for them developing PNES. ADHD, there are a number of patients who have PNES who also have ADHD. I don't know if there's any, again, I don't think there's been any particular study that looked at that. And then in terms of memory, what we do know is that patients with non-epileptic seizures have cognitive problems. They report it, and actually when you test, there are sometimes issues that show up. Typically, the self-report is that there are memory problems, there may be attention problems, and there may even be some word-finding problems. Now, this could be affected as well, if there's other comorbidities. So, for example, depression or anxiety also do a number on our cognitive functioning. But for sure, we see that patients with non-epileptic seizures have cognitive difficulties that they report. We actually see them on testing in cases. And I've had some really interesting cases that went through treatment and the seizure stopped, And then for whatever reason, we retested. I don't even know why, this happened. But with certain patients, and we even had a case study that we wrote up where we retested a year or two later, and the cognitive functioning had improved really dramatically. So when you're having these seizures, these are dissociative episodes. They take a lot of energy. They are very disruptive, not just externally, but internally. So they can affect your cognitive functioning. And when they are managed, and when there's a recovery from the seizures, you typically will see that patients will report it themselves. But even if you were to test, you might also pick up on these recoveries, in terms of memory, attention. Yeah. So I hope I answered all the questions. Yeah. Tracy's asking something. Can you unmute yourself?
I got a question. You have a support group, don't you? But it's not for non-epileptic seizures.
I have two support groups. I have a epilepsy support group that started with COVID, and it just went on. We just loved it, and now we have some old timers or whatever that come every month. And then I have a non-epileptic support group. But that group, I've limited it just to patients who have completed treatment at our program. It was otherwise going to get huge, and it was going to be unmanageable for me. So right now we have probably 20 people who, 15, 20 people who come in. It's a drop-in group, so sometimes someone won't come for several years and then they drop in. I've been running it for a long time. What I usually say is if someone is looking for a support group, I believe fndhope.org now offers a support group or two. I could be wrong, but I think I saw that at one point, fndhope.org.
The reason I asked is because I joined a support group and I thought it was you.
Oh.
I mean, and I said, I thought it was a non-epileptic support group, and you said this wasn't for non-epileptic seizures, and that's why then I quit going because I was looking for one just for non-epileptic seizures.
Hope.org, they have one that is for non-epileptic seizures.
Mm-hmm.
Maybe Epilepsy Alliance America at some point will want to host a non-epileptic seizure support group. I think they're wonderful. It really, the support group that I run, like I said, it's been running for years. And it's just wonderful to see how patients help each other, right? I'm pretty quiet during most of the group, and it's just, being able to understand each other, but also to be able to sometimes have gone through something, and be able to supply, an idea, some way to either a resource or, something that they tried and that worked. Good, I say support groups, wonderful. Maybe at some point, if I have more time, I'll open up a support group that is just for everyone. But again, it has to be manageable because everyone has to be able to speak, right? If you have too many people, it just gets.
Yeah.
Yeah.
Thank you very much.
Okay. Well,
You helped a lot.
Good.
Fantastic. I think that is all of our chat questions. If anyone else has a question, please put it in the chat or raise your hand. And we really appreciate your time this evening.
Oh, look, I see Epilepsy Alliance America is considering a group for PNES. They have started very small with some, I didn't see it all, but.
With some of the PNES scholarships, but
Oh.
stay tuned. There's some of the recipients of the PNES scholarship.
I learn something every day. I love doing these because, the more you talk with people, the more you learn. Somebody's asking what's the code for continuing ed. That I don't know.
I just sent the link. If you would like Act 48 credit hours, you can click the link that is in the chat and complete that post survey.
Wonderful. Well, thank you everyone for being here tonight. I hope that, this has helped somewhat, and, and you have my email, so, reach out if something comes up. And Allison, I'm so pleased to have met you because we've been LinkedIn buddies for a while. Allison, I'm waiting for you to graduate so that I can list you in my my referral page. Okay. All right. Well, thank you.
Thank you so much, everyone. I hope you have a great evening.
Bye-bye.